My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center in Boston, Massachusetts. So over the last 20 years, we've really come to appreciate that breast cancer is not one disease. It's a family of diseases. And this became quite clear to us with the publication of the first gene expression analyses identifying the molecular subtypes of breast cancer. That seminal work, now led by Teresa Sorlee and Chuck Peru, published nearly 20 years ago, which is hard to believe. But first, identifying for us these molecular subtypes, so terms that are now quite familiar: luminal A, luminal B, the HER2 subtype, and the basal subtype. Of course, in clinical practice, we use immunohistochemical surrogates to identify these subtypes. So our luminal A tumors are those that are ER/PR positive, HER2 negative, and tend to be lower grade tumors. Our luminal B tumors are ER/PR positive, HER2 negative, but tend to be higher grade tumors. And some HER2 positives will be in that luminal B group. But the majority of HER2 positive cancers are, again, identified immunohistochemically as overexpressing the HER2 receptor or having an elevated copy number by FISH. And then the basal subtype is, of course, best represented by our immunohistochemical surrogates of being a triple negative tumor. So having an understanding of these different molecular subtypes, having an understanding of how important they are in predicting response to treatments, as well as overall survival and outcomes for our patients, has really allowed us to tailor our multidisciplinary approach. We tend to use chemotherapy before surgery in women who have the high-risk disease subtypes, so the triple negative subtype and the HER2 positive subtype. We know those women are going to require chemotherapy as part of their overall treatment plan. And so we ask if there's any benefit to giving this in the preoperative setting. Of course, in HER2 positive disease, we're talking about chemotherapy combined with anti-HER2 therapy, not chemotherapy alone. But there have been multiple neoadjuvant trials demonstrating that in these appropriately selected women, again, the HER2 positive and the triple negative subsets, that we can achieve quite high rates of pathologic complete response when giving the chemotherapy before surgery. We know that those rates of PCR translate into improved overall outcomes for those women who achieve PCR. And as a local therapist, I'm asking the question, is there any secondary benefit that my patient can achieve from receiving these treatments before surgery? Again, treatments that I know they're going to receive after surgery. So we're looking at rates of downstaging the tumor to allow breast conservation therapy. And we're also now looking at the ability to downstage the axillary lymph nodes to allow us to avoid having to perform a completion node dissection. We certainly don't think that all patients with HER2 positive or triple negative disease need chemotherapy before surgery. In those with very small tumors, so clinical T1, N0 breast cancer patients, we still take those patients to upfront surgery, and the information from the surgery, the final pathologic tumor size and the lymph node status, are then incorporated into the multidisciplinary planning. My medical oncology colleagues may choose to omit a full course of chemotherapy or give only a shortened course of chemotherapy in someone with triple negative disease who in fact has a T1 N0 tumor at the time of surgery. HER2 positive patients perhaps can only be treated with dual anti-HER2 therapy or single agent anti-HER2 therapy at an adjuvant setting if in fact they have low volume disease. And there are many studies now being planned or being ready to accrue, looking at, again, opportunities for de-escalating therapy in these high-risk subsets, largely based on using these treatments in the preoperative setting, looking for PCR, and then deciding who it is safe to avoid additional treatment. So chemotherapy before surgery is often considered in women with, again, HER2 positive or triple negative disease if the tumor is approaching 2 centimeters or if there's any evidence of disease in the lymph nodes. We work together as a multidisciplinary team to discuss what are the potential secondary benefits of giving this treatment first, again, downstaging for breast conservation or potentially eradicating the axilla. And then our medical oncology colleagues, again, are considering if a patient does achieve a PCR, is there an opportunity to de-escalate therapy? And we certainly now know with data from the CREATE-X trial, as well as the Catherine trial, that women with triple negative disease or those with HER2 positive disease who do have residual disease at the time of surgery after neoadjuvant chemotherapy, that those women may benefit from additional adjuvant systemic therapy. So it really has become a nice team approach with the understanding of the biology of the disease, the understanding of the advantages of preoperative therapy, not only in refining adjuvant therapy, but the advantages of preoperative therapy in downstaging tumors or sterilizing the axilla. Now, the hormone receptor positive HER2 negative subtype, that remains a bit of a challenge still in deciding when preoperative therapy may be advantageous. We live in an era where we're using genomic assays to try to actually de-escalate the use of systemic therapy in these patients. And so if someone is not going to be a candidate for adjuvant chemotherapy for their hormone receptor positive disease, then I certainly don't want them to get preoperative chemotherapy for their hormone receptor positive disease. That wouldn't make sense. So in lower risk hormone receptor positive breast cancer patients who have larger tumors where we might be hoping to downstage to achieve breast conservation, we are more and more considering the role of neoadjuvant endocrine therapy in that population, because again, if there's no indication for chemotherapy, we don't want to use it just to shrink tumors. There has been increased interest in this, ironically spurred by the COVID-19 pandemic, where we were not able to take women to the operating room with the same timeliness as we normally would in the United States. And so in our hormone receptor positive HER2 negative subgroup, again, where surgery would frequently be used first, we were in fact using more neoadjuvant endocrine therapy as a bridge to surgery. I think that helped us to really start to think about the role of neoadjuvant endocrine therapy more carefully in our population. And I'm hoping that we'll see new trials and new efforts towards really looking at how neoadjuvant endocrine therapy can be safely incorporated into treatment for a wider variety of patients. But to summarize, the use of chemotherapy before surgery is largely driven by molecular subtype. We now understand the importance of refining our treatment strategies by molecular subtype. In women who are not candidates for chemotherapy in the adjuvant setting, we should not be giving them chemotherapy in the neoadjuvant setting. And I really think we have an opportunity in the hormone receptor positive subgroup to really think about maybe a broadened opportunity for the use of neoadjuvant endocrine therapy.